Good morning. Welcome back to Open Med School. Today I'll be discussing a clinical case. This part of series in emergency medicine. This is a 26-year-old healthy female who presents to the emergency department with palpitations for the last 30 minutes. The ECG is showing narrow complex QRS. There is tachycardia. No obvious P waves are there. You can see the heart rate is around 150. So, no visible P waves, BP is stable, there is no chest pain. So, hemodynamically, the patient is stable. That is one thing that you should always look for when somebody comes with the tachycardia. So, here again you can see the rate has become 193. No P waves are there. So, this is a case of supraventricular tachycardia, SVT. Any narrow complex tachycardia, unless proved otherwise, we take it as a SVT when the rate is more than 150. Sinus tachycardia usually goes up to 150. It can range up to can go above that, but usually 150 to 250 we take it as supraventricular SVT. If the patient is hemodynamically stable, you can attempt Valsalva maneuver, and which is, if it is ineffective, you may go for pharmacological therapy if the patient is stable. The drug of choice is adenosine. Adenosine is administered as 6 mg IV rapid push, followed by 20 ml saline for flushing it, because it has to be administered rapidly. So this is the rhythm strip. So this is a patient has got a narrow complex tachycardia. There is a brief period of asystole followed by the norm going to sinusal thumb. So if vagal maneuvers are ineffective, rapid IV bolus of adenosine 6 mg followed by saline flush. Again, if it is ineffective, you may go for a second bolus of 12 mg, that is double the dose. Adenosine may cause brief asystole. This typically lasts only few seconds and is well tolerated. So this is injection adenosine 6 mg per 2 ml. So start with 6 mg. You can double it. Another dose can be given, and some people say you can give a third dose of 12 mg. Adenosine is a naturally occurring purine nucleoside. We are aware of the ATP, the same adenine. Purine is combined with the ribose forms the adenosine. This terminates paroxysmal supraventricular tachycardia, PSVT. So adenosine is a drug of choice. For terminating paroxysmal SVT due to reentry occurring in the AV node. What is the mechanism of action? Adenosine binds to adenosine 1 receptors in the cardiac AV node. Adenosine receptors are present throughout the body in various systems. The vascular endothelium, the cardiovascular system, urinary system, many places it is present. In the AV node, it is the A1 receptor, and vascular endothelium, it is a A2 receptor. This activates the potassium currents and inhibit adenyl cyclase and reduce calcium influx. So it produces hyperpolarization and slows or blocks the AV nodal conduction. So this is the explanation. You can see this is the potassium channel. This intracellular, it is activated and the calcium influx is decreased. So this leads on to hyperpolarization and a transient blockage or reduction. So adenosine hyperpolarizes AV nodal tissue and transiently blocks conduction, especially in the AV node, by increasing the potassium current and decreasing the inward calcium current. So normally potassium tries to go out. So here potassium channels are activated and the calcium channels, calcium entry is decreased to the cells. The most important point to remember that is that the action is within seconds, very immediate, and half-life is extremely short, less than 10 seconds. It is rapidly degraded by erythrocytes and vascular endothelium via adenosine deaminase. So it is a very fast acting and fast degradation. So this is to be remembered, extremely short half-life, less than 10 seconds. So it should be administered via rapid IV bolus so that it acts before degradation. So routinely we use a 3-way tap, connect a saline 20 ml, then lock it in such a way that adenosine is injected, change the tap and flush the IV line with 20 ml of saline. That is how you give the adenosine. What are the indications? It is a first line treatment for narrow complex regular tachycardia originating from the AV node, either the AVNRT or AVRT. Sometimes it is used as a diagnostic aid in wide complex tachycardia to unmask atrial activity. So the first line treatment. Adenosine is highly effective in terminating AV nodal tachycardias. Contraindications are absolute contraindication. The patient has a sick sinus syndrome without a pacemaker, second or third degree AV block. Relative contraindications are bronchial asthma, patient is on theophylline or dipyridamole. Dipyridamole will potentiate the effect. Theophylline is antagonistic. Adenosine should be avoided in people with bronchospastic lung disease as it can precipitate bronchospasm. What are the adverse effects? Flushing, chest tightness, and shortness of breath. What is the reason for the flushing? I already said that the A2 receptors are in the endothelium. Once they are activated, there is a vasodilation. Sometimes anxiety or sense of impending doom can occur. This occurs especially when the patient goes into transient asystole. Adverse effects are usually transient and include flushing, chest discomfort, dyspnea, and a brief period of sinus arrest or AV block. Remember this. The summary: adenosine is a first-line therapy for AV nodal tachycardias, very short half-life. Transient adverse effects can occur. Warn the patient before administration to avoid panic. Hope you have understood how to administer adenosine, what are the indications, what is the mechanism of action. Stay tuned for further videos. Thank you.